as we're in the theme of science, we're going to continue now with our Research Roundup. And as I mentioned at the beginning, science is a huge focus. We know that we wouldn't be where we are today with our CFTR modulator drugs if it hadn't been for investment in research and digging deeper into the basic science of what's going on with CF. So I'm going to welcome all of our speakers, and then I'll introduce the first person who's going to speak to us this evening. So just for the benefit of everybody's listening and whoever might be taking notes or just keeping track of who's coming up, we have Dr. Rini Bhatnagar, and she's going to speak to us about the impact of COVID. So it's really nice. It ties in with Professor O'Neill's talk with us earlier. We're then going to have Dr. Martina Hayes. We've Dr. Audrey Tierney on the way, and we've Dr. Tamara Vag, and we also have Dr. Michael Toomey as well. So I hope you get a real flavour of the type of research that CF Ireland is interested in and that we're supporting. And Dr. Rini is currently pursuing her PhD in public health, and you're based at UCD, I think, with Professor Patricia Fitzpatrick, I think. Yeah. So I'll hand over to you, and you're welcome. Thank you.
Thank you. Thank you so much. Good evening, everyone. So today I'm going to present results of our study where we focused on the various ways in which adults suffering with cystic fibrosis, children suffering with cystic fibrosis, their parents and their families managed their day-to-day lives during COVID-19 pandemic. This is a study conducted jointly between UCD and Cystic Fibrosis Ireland, the support and advocacy organization for people with CF, and I am a PhD student, funded through a grant from Health Research Board. Early in COVID-19 pandemic, it became very clear that persons with CF were at greater risk from COVID-19 due to compromised lung function and other comorbidities. Therefore, the overall aim of this study is to assess the various ways in which adults with cystic fibrosis, children with cystic fibrosis and their families manage their day-to-day lives during COVID-19 pandemic. The objectives were to determine impact on hospital visits if alternative routes of care were used, access to medications, and impact on mental health. A self-administered questionnaire developed by UCD and Cystic Fibrosis Ireland was uploaded on Smart Survey UK, which is a GDPR compliant survey tool, for a period of 6 weeks. The survey was hosted by CF Ireland and advertised widely through various social media platforms such as Twitter, Instagram, Facebook, and various WhatsApp groups. A copy of participant information leaflet was made available on CFI website for participants to review. The total number of participants were 242. Participants were people or adults with cystic fibrosis, children with cystic fibrosis, and parents of children with cystic fibrosis. In the next two slides, parents of children with CF are shown in orange and people with CF are shown in blue. The left graph shows various sources from where respondents obtain information about COVID-19, and the three major sources for both adults with CF and parents of children with CF were CF Ireland website, HSE website, and television. Looking at the graph on the right, 77.3% of people with CF and 69.4% of parents of children with CF were satisfied with the information. Now, looking at the top left, 47.5% of adults with CF and 55% of parents of children with CF had to put off their own or their child's hospital visits during COVID-19. Looking at the bar graph in the right, we can see that the period of delay ranged from 1 month to as long as 6 months. The majority of children had a deferral for a period of 3 months, but some deferred up to 6 months as well. It is also important to note that a quarter of people with CF or adults with CF deferred for a period of 6 months or above. The bar chart below shows the key reasons for deferral, and the main reasons for deferral were fear of COVID-19 or, in a smaller number, closure of hospital unit. This slide looks at the postponement or cancellation of CF care during COVID-19 in adults and children with CF. Top line of the graph is related to adults, and dark blue means postponed or cancelled. Among adults with CF who deferred, deferrals majorly impacted rehabilitation therapies, medical care in hospital, appointment with GP, and diagnostic tests. Children are shown in orange graphs, and dark orange means postponed or cancelled. Among children with CF, around 43% of them deferred their rehabilitation therapies, 54% of them deferred their medical care at home, 30% had to postpone or cancel their appointment with GP, and around 47% of the parents had to defer their child's diagnostic tests. Moving towards the medical care of people with CF during COVID 19, now looking at the top left, online consultation were new to around half of the population, and majority of them found it helpful for them. Looking at the second bar above, overall, around 53% of them received their prescriptions via email, and those who did, more than 80% of them found it beneficial for them. The third and the fourth bars show that relatively smaller number of people with CF used online education or online physiotherapy classes, but those who did found it really beneficial for them. Turning to the medical care for children with CF during COVID-19, the graphs in the top row shows various ways through which child's health professionals were approached, and the graphs in the lower row shows usefulness of each modes of consultation. Now, looking at the online consultations on the top left, that is in orange, blue, and green colors, we can see online consultations were new to people and some people found it helpful for them. Looking at the second bar in the top chart above, overall, around 55% of them received their prescriptions via email, and those who did, more than 80% of them found it beneficial for them. The third and the fourth bar shows that in a smaller number, parents and children used online education or online physiotherapy classes, but those who did found it really helpful for them. We also looked at the availability of medicines and PPE, and we found that while medicines were available for many, it is very important to note that around 12% of parents of children and 24% of adults with CF found it challenging to access medicines and treatments for CF, of whom one child with CF and seven adults with CF had to stop taking medicines and had to find an alternative. Protective equipment such as face masks and gloves were easily accessible for more than 80% of the participants. However, few of them found it difficult to find. Majority of people with CF and parents carried hand sanitizers when they went outdoors. Focusing on the precautions taken by participants, many of them complied with public health social distancing precautions, but importantly, in addition to these standard public health infection control practices, over 40% of them whole family cocoon, almost 40% did not visit shops and had food and medicines delivered at home, and a number have fully cocooned during the COVID, living separately from rest of the household. Looking at the impact of COVID 19 on mental health, in the graph on the left, we can see that 74% of adults and 71% of children with CF experienced mental health issues during the pandemic. Looking at the graph on the right, the key mental issues were increased anxiety and stress, with parents of children reporting their children had increased stress, particularly, and excess anxiety, featuring strongly in persons with CF, with smaller numbers in both the groups having difficulty in sleeping, irritability, and feelings of insecurity. This slide shows mental health issues in children with CF based on age of the child. In the chart above, the top of this, it is clear that overall mental health issues increased with age of the child. The table below shows further detail about mental health issues based on age, and we can see that primary school children had highest rates of anxiety and difficulty in sleeping, with senior school children highest in remaining categories. Overall, a large number of both adults with CF deferred their own visits, and parents of children with CF deferred their child's hospital visits up to 6 months. The key reasons for deferring were closure of hospital unit and in a smaller number coming in contact with coronavirus. This is of great concern as routine examination is the key to early intervention in infective exacerbations or picking up of any signs of clinical deterioration. A large proportion of both people with CF and parents found online consultation new and were very satisfied with this method. Prescription via email was also popular amongst the participants, and majority of them found it very helpful for them. This is a method which could be usefully continued post-pandemic as well. I would like to thank those who participated in this study. Thank you everyone for listening today.
Thank you, Rini. That was excellent. We're hoping to have a Q&A session towards the end. So if you can stay with us for then, we can direct some questions to you then. I think it takes skill to make a very dense questionnaire accessible to everybody else. So thanks for breaking it down clearly for us all. Thank you.
Thank you so much.
We're going to move from UCD now to Cork, and Dr. Michael Toomey is available for us. Oh, I'm sorry. Are we going with Dr. Martina Hayes?
Yeah, it's going to be Martina.
Yeah, thank you so much. So Dr. Martina Hayes, I'm sorry for having you on standby and then giving you a fright there.
No, no worries, you're fine.
You're in Munster, but I'm not sure that you're at Cork. Are you? Where are you at the moment?
I am in Cork.
You
I'm
are
actually
in Cork.
inside in my very messy office at the moment.
Oh, that's fantastic. I think everybody's happy to have you. It doesn't matter what the background is like. And you're going to speak to us about dental care. So I'll let you take over there. Thank you.
Absolutely. And thank you so much for giving me the opportunity to talk. This is a collaboration between Cystic Fibrosis Ireland, the dental hospital here in University College Cork, and the adult CF team in CUH. And the main aim of our study is to look at the oral health of people with cystic fibrosis, and also to look at the implications of cystic fibrosis for people providing oral health care. So we all know that the management and the life expectancy of cystic fibrosis has dramatically changed. So it's a great time to focus on the management and the prevention of chronic diseases in people with cystic fibrosis. And gum disease and dental caries are among the most common chronic diseases in the world. So we have worked with patient advocates from Cystic Fibrosis Ireland to better understand cystic fibrosis. We collected 70 questionnaires completed by people with cystic fibrosis and 140 questionnaires completed by general dental practitioners. And also, despite COVID, we've completed oral examinations on the first 25 participants in the study. So this study is in its early days, and it's certainly too early to present results, but the Health Research Board have given funding for this study to continue well into 2023. So we hope that we'll collect a lot of valuable data. However, over the last year, working in the adult CF unit and conversing with the staff and also the people attending the unit has uncovered more dental implications than I would have expected from the outset. I'm just going to preface some of the things I'm going to say by saying that obviously when you're prescribed something by your CF team, it's for a specific purpose and it should be taken as prescribed. However, some medications do have potential dental implications. And I think that this project has given me an opportunity as a dentist to bring that perspective into the CF team. So many of you will be familiar with oral nutritional supplements, which are prescribed to help people with cystic fibrosis maintain their target body mass. However, there's a wide variation in the sugar content of these supplements, and some of these, if sipped throughout the day, could be very damaging to the teeth. Also, 40 to 50% of adults with CF have CF-related diabetes, and this is a significant risk factor for gum disease. We know that the success of the treatment that we provide for gum disease is strongly related to how well controlled that diabetes is. And what we also know is that having gum disease can negatively affect your blood sugar control and increase your chances of suffering from other common long-term complications of diabetes. 1/3 of people with CF develop osteoporosis, and one group of drugs that can be used to treat this are the bisphosphonates. People with CF may start bisphosphonate therapy at a relatively young age, such as in their 20s or their 30s, compared to in most of the population, people taking bisphosphonates are more likely to be in their 50s or their 60s. And in dentistry, they're a bit of a red flag drug to us, so we try to avoid extractions in those who have been taking oral bisphosphonates for more than 3 years. So although bisphosphonates are undoubtedly beneficial for the management of osteoporosis, they do impair bone healing and remodeling. So this results in an increased risk of the development of a condition called osteonecrosis of the jaws, following common surgical dental procedures like wisdom tooth extraction, a normal dental extraction, or having a dental implant placed. Osteonecrosis, which is essentially bone death, can prevent the surgical area from healing, leave the bone exposed, and may lead to other complications. Also, in advanced CF, solid organ transplant may be necessary, and due to the multi-system nature of the disease, this could be lung, heart, liver, kidney, or pancreas. And patients are required to be certified as being dentally fit before surgery, because we need to reduce the risk of dental disease going into surgery, but also because people are going to be on long-term immunosuppression, we need to prevent the risk that they're going to have dental disease in the future. Unfortunately, in my experience, the dentist is contacted quite late in the process, and they can be urgency to get the person on the transplant list. So very often, given the amount of time we have to work with, extractions are often the treatment of choice because we don't have enough time to do protracted courses of gum disease treatment or root canal treatment in an effort to try and save the teeth. So now that we have a dental presence in the CF unit, we feel even more strongly that targeted oral disease prevention strategies are really important for people with cystic fibrosis. And that's why I call this presentation, Mind Your Teeth and Your Teeth Will Mind You. From the outset of this research, I hope to find out if people with cystic fibrosis have poorer oral health. But actually now my focus has shifted because I believe that people with cystic fibrosis should aim to have little or no dental disease. So it's well worth being a regular dental attender and to highlight to your dentist if you're diabetic or if you have osteoporosis, if you're taking an oral nutritional supplement or taking a bisphosphonate, or if there's any discussion that you may be needing a transplant at some point. The more information that your dentist has, the better that they can tailor an oral health plan for your needs, with the ultimate aim of fixing any problems while they're small or preventing oral diseases from ever taking hold. Here in the dental school, we've been inundated with requests for a lecture to be given to dentists on cystic fibrosis ever since we sent out our questionnaire, as many dentists held their hands up and said that they understood very little about cystic fibrosis beyond its effects on lung function. So we hope to deliver that lecture next autumn. And we've also written a series of informative articles for dentists in the Journal of the Irish Dental Association. So we hope to raise awareness on your behalf also. I'd like to state a heartfelt thank you to Cystic Fibrosis Ireland for all your support, and in particular Caroline and Rory for the time that they gave speaking to us, and also to Professor Barry Plant in the adult CF unit here in Cork and the CF nurses who've been absolutely amazing to work with. I've just put my contact details up here if anybody wants to know more about the research that we're doing, or if you just have any dental queries or anything that relates, I'd be absolutely delighted to talk to you because, as I say, we're quite early on in the day with this research, but we're finding more and more links where there is a role for really optimizing good oral health care for people with cystic fibrosis.
That's fantastic. Thank you, Dr. Hayes. It's really useful to see just a joining of the dots between the medication that we're on and the impact that it has on our teeth. As somebody from the generation with lots and lots of Scandi shakes, I know that it's something.
I didn't want to mention it by name.
Well, yeah, and other supplements that are equally nutritiously supplemental, you know, and I know there was other medications that used to be delivered by syrup, and, you know, unfortunately, for all the benefits, there are also consequences. So it's marvelous to put dental health on the radar and ensure that people with CF and particularly younger people are getting better dental health and dental care as a result. Thank you so much. We're going to move now, staying in Munster, we're going to move to Dr. Audrey Tierney. And Dr. Audrey Tierney is a dietitian and she's going to speak to us about diet and CF. So I'll leave it to you. Thank you for coming.
Thanks, Patricia. Great, thanks, Jane. So I'd like to thank Cystic Fibrosis Ireland for inviting me to speak today on the topic of diet and CF. And the title really is the need to focus on diet quality as well as quantity or consuming enough food to meet our nutrient targets. So for the next 8 minutes or so, sorry, now just move. So for the next 8 minutes or so, I will speak about the changing face of nutrition and cystic fibrosis, and how we're observing an emergence of overweight and obesity and what the data is telling us, or our registry data sets are telling us. What we know about what people with CF eat in terms of diet quantity and quality. And I will introduce a study that we're about to undertake in the University of Limerick, looking more around diet quality in cystic fibrosis, if anyone would like to get involved. So I suppose until the 1980s, a high energy diet was advocated or advised for people with CF. And the requirement was that, you know, because of frequent chest infections and that high energy requirement, that people with CF needed to consume high energy to meet energy targets. But it was advised that people with CF consume these diets that was high in energy but low in fat, because pancreatic enzyme replacement therapy was not available and the first preparations were not really effective at that time. So a high energy, low fat diet was really impossible to achieve for people with CF, and it resulted in malnutrition, with inadequate intakes also being common. So in the late 1980s then, research suggested a potential benefit of providing a high fat, high calorie diet with maximal enzyme dosing. And this led to significant improvements in nutritional status, which was then linked with survival. However, malnutrition was still prevalent, and a low BMI and a low fat-free mass or muscle mass was linked with poorer lung function. So the availability of interventions such as oral nutrition supplements, Scandi shakes, as was mentioned earlier, and enteral nutrition where needed, were utilized to really try and increase BMI or maintain BMI. So looking to current patterns in CF and nutrition, we know that drastic improvements in CF treatments, including the development of CFTR modulator therapies and multidisciplinary and standardized patient care, have increased the median predicted survival age of CF. There has been a significant increase in well and well-functioning adults, whereby the majority are fully operationally engaged. We're seeing an increase in the aging population, or adults greater than 35 years. But along with this, we're starting to see significant comorbidities in line with this age. So for example, emergence of overnutrition, which I'll talk about further, and an emergence of metabolic diseases, some types of cancer and diabetes complications. Fortunately, there is a parallel reduction in that malnutrition spoken earlier, you know, that was prevalent in the 1980s and the 1990s. So we're starting to see a reduction in that prevalence. So it is established that nutritional status and lung function are highly correlated or associated in both children and adults. And in this graph here, what we can see is that as BMI down the bottom here increases, we're seeing an associated increase in lung function, which is along the y-axis here. This is for both males and females. But I just want to point out that around the BMI of around 25, which is the cutoff point for the start of a BMI being classed as overweight, we're seeing minimal effects on lung function past this BMI. So there's a plateau or minimal gain for lung function beyond a BMI of 25. And this has been reported in most epidemiological studies. This graph is from the American Data Registry in 2012, and this shows that BMI is increased by 1 unit from 1992 to 2002 to 2012. And this is across all age groups. So if we look at somebody aged 24, in 1992, there was a BMI, an average BMI of 19.8. In 2002, that BMI increased to about 20.8. And in 2012, it's gone up to about 21.6. This was further looked at by a study by Stevenson et al. Back in 2013. And they looked at the distribution of BMI across 3 decades. And what you see is an overall shift to the right. So the red line here indicates the cutoff for BMI for overweight. And so while more patients with CF are moving away from that extremely underweight range, we're seeing more in the overweight category. There was an increase from 7% to 18% in the 3 decades that they looked at. It's nicely depicted here in this graph from the Canadian Data Registry. So we can see an emergence of overweight and obesity from 1987 to 2012, depicted by the red color. But it's just also to note here that underweight or the malnutrition has not gone away. It's still present. And although it's decreasing, it is still a significant proportion. So given the BMI and the lung function relationship, nutritional interventions in CF have mostly been targeted at trying to increase that BMI with increased calorie or high energy, high protein diets. The term legacy diet has evolved or come about in the last few years, and this really is the evolution of the CF diet, which often consists of suboptimal food choices, which are focused on high calories and fat, instead of, I suppose, high quality or nutrient quality. And we know in the general population that consumption of diets that are energy dense but nutrient poor are associated with chronic health outcomes such as cardiovascular disease, type 2 diabetes, metabolic syndrome, and a variety of cancers. From the Healthy Ireland report in 2015, we know that there is an obesity epidemic in Ireland and in many westernized countries, such that 1 in 4 children and 6 in 10 adults are overweight and obese. And people with CF don't live in different, cultures or environments. We still live in the same obesogenic environment as the general population. So whereby it's, the access to convenient or fast food that's high in fat, salt, and sugar is readily available, and trying to meet our physical activity goals can be difficult at the best of times. We know from studies on CF modulators that some have had more impact on BMI than others. And in 2020, this review was conducted, which looked at all the studies carried out on CFTR modulators and their impact on BMI. And lots of kind of findings were proposed. The main point there is the bottom one, which says that the effect of the modulation therapies on anthropometric parameters really depends on the genetic mutation and the type of modulation. So there was significant weight gain with ivacaftor for people with G551D. There was mixed effects in other mutations with other drugs. But so it depends on the modulation therapy and on the genetic mutation. BMI doesn't really provide a lot of information on body composition, so fat mass or muscle mass. And myself and some colleagues in the Alfred Hospital in Melbourne, where I worked for 10 years, undertook a study that looked at patients with at least one copy of the G551D, and we looked at body composition measurements across a 2-year period for patients who were prescribed ivacaftor. And what we saw was for weight and for fat mass and for BMI, we saw significant increases from baseline to 1 month and from 1 month to 6 months post-treatment. And people in the literature were starting to get worried around this time, would these gains continue? But what we found was at the 2-year mark, we found that levels really plateaued off for weight, for BMI, and for fat mass. So we didn't see that increase post really 6 months. For fat-free mass or for muscle mass, what we found was an increase from baseline to 1 month of ivacaftor treatment, but this didn't continue post 1 month stage. So there's lots of proposals around how genetic modulators lead to weight gain, in that some research has shown that enzymes potentially work better. There's a decreased work of breathing, a decreased in that high energy requirement, improved appetite, and an overall efficient energy use. So it's easy to see then how the current environment and current therapies for cystic fibrosis may be negating the need for a high energy diet in many people with CF. And continuing with the legacy diet or the traditional approach to diet may be contributing to excessive weight gain in some people with CF. But I have to also point out that this weight gain that we're seeing in the registries also exists alongside malnutrition. And so we have to really look at the individual person when we're looking at nutritional therapies and nutritional interventions. There really is, I suppose, a need to look at overall diet quality in cystic fibrosis. So looking beyond energy, protein, carbohydrate, and fat targets, and really looking to see, is the current nutritional recommendations suitable for all? What do adults with CF eat? And this is a study that we're undertaking in the University of Limerick at the minute by systematic review. So we're looking at all the studies that report what adults with CF eat and looking at them cumulatively to see what the story tells us. And what we're seeing is that energy intakes typically are around 90 to 140% of the healthy population. Energy from fat is very much in line with the general healthy population or the general healthy population guidelines. So we recommend about 30-35%. But micronutrients or your vitamins or minerals are inadequately taken for patients with CF who are just looking at diet alone. However, they can be and were achieved with supplementation. Around diet quality, there's very few studies. So 4 studies reported on diet quality, and there was very much mixed findings. 2 studies said that there was lower diet qualities compared to healthy controls, and that people with CF had higher intake of trans fatty acids, sugar intakes, lower fiber intakes, and they weren't meeting population dietary guidelines for fruit and vegetables. And one study actually said that there was good diet quality reported with patients with cystic fibrosis, higher than recommended dietary intakes of grains, and that intakes of fruit and vegetables were in line with population guideline recommendations. So some mixed bags of findings there. At the Alfred Hospital in Melbourne in 2012-2013, we undertook a study asking patients what drove their choices to eat a certain way, or what were their underlying reasons for eating a certain way. And of note, it wasn't a high-fat diet that was a priority for our cohort of patients. It was a stronger preference for eating a healthy diet that tastes good, that's easy to prepare, and that's higher in energy and protein and fiber more so than fat. So I suppose the current challenge, and what I'm interested in exploring further, is to look at the optimal diet for individuals with CF and how to identify that it's adequate in calories, macronutrients and micronutrients, so that quantity and quality is taken into consideration, that we avoid malnutrition, that we promote good health, which includes long-term pulmonary function, because we know of the close relationship there, and that we minimize CF-related gastrointestinal symptoms, which is also really important for people with CF. So with that, we're undertaking a study that's with Cystic Fibrosis Ireland and funded by the Health Research Board and CFI. And we're looking for adults with cystic fibrosis to come forward and tell us a little bit more about what they're eating and why they're eating a certain way. So the aims of the study is to look at nutrient intakes, to look at overall quality of the diet, and to look and see if there's any associations between diet quality and things like quality of life, lung function, gastrointestinal symptoms. And if people would like then to get involved in some conversations or focus groups, looking at what drives people to eat a certain way, can people with cystic fibrosis eat a healthy diet, what promotes healthy eating, and what really stops people with cystic fibrosis from eating a healthy diet. So people with cystic fibrosis will be invited to participate through the CFI charity website and also through membership forums. And also I've left my details there and make the slides available if anybody is interested and want to contact me. Thank you very much for your time.
That's fabulous. Thanks. I found that really interesting as well. Oh, I'm sorry. Had you one more slide?
No, happy to
okay. I'm jumping in on top of you there. That's marvelous. And I know, just having a quick glance at the attendees, I recognize that there are some adults with CF who are on this evening who are viewing, and I'm sure they'll spread the word as well. It's definitely time for us to embrace a different kind of diet than the legacy diet, I think, moving forward. Thanks, Dr. Tierney. I just wanted to flag with everybody that we are taking in the questions. So there is a Q&A box that you'll see. It's different to the chat box. It's a Q&A box, and we're monitoring what's coming in there, and we're gathering them for the Q&A session that we're going to have towards the end. And I can see that Dr. Michael Toomey is ready first. That's marvelous. And I'm going to introduce Dr. Toomey now. You may recognize him because he has presented previously at the conference, one of our previous conferences. And Dr. Toomey is coming to us from Cork. And perhaps you could fill us in on what you're working on at the moment, Michael. Welcome.
Hi, how are you folks? And thank you for having me this afternoon. I'll just start mine. Can you see that slide?
Not yet.
Not yet, no.
1 sec, sorry.
I'll let you work away with that, and I'll give you a proper introduction. I think sometimes when you know somebody, you kind of skip over it a little bit. Dr. Toomey is working in business, and you've presented previously in relation to your work to do with people with CF attending appointments and the interaction between people, and you produced a really useful handbook. So I'm looking forward to hear how you're getting on with your current research. Thank you.
Thank you. And thank you to everyone who has attended this evening/afternoon. So yes, I presented before in the CFI. Today I'm going to give you a short bio on myself and where I am at the moment in terms of my research, etc. The the research approach that I took in relation to the paper I'm presenting this evening, and I suppose the findings from that. Okay, so just to give you a bit of a background, I'm a patient with CF myself, so shout out to all the patients with CF that are out there. I'm also working now with the Health Innovation Hub Ireland. That's the new positions I've got following finishing my PhD. I'm a family man as well. Formerly an entrepreneur, I had my own IT business, and I was formerly a biochemist. The inspiration came from my sister with CF. Motivation, being a patient myself, and I suppose being interactive with, I suppose, patients in the CF community within Ireland. And the research that I've been engaged in was funded by CF Ireland and the Irish Research Council. So previously you would have seen me talking about declarative long-term memory, okay? And I suppose these are the memories that we use every day, okay? Semantic memory being knowledge memory, and I'll be talking about that again in relation to health literacy, okay? Episodic memory being our memory of events, birthdays, particular medical appointments, particular symptoms. And then I suppose autobiographical memory, which would be our health journey, okay? From our very early days as a child with CF right through to where we are now. So the lens that I took, folks, was, I suppose, looking at the people, the processes that happen within the medical appointment, the technology that may be used, and focusing very much on the data that we recall, or that we need to recall, or that we need to remember. Okay, so the people, lo and behold, it's the doctor is one of them, and the doctor, his main, I suppose, job within the medical appointment is to make a diagnosis, which is a cumulative decision making using key data that he gets from examination, but also that he gets during the medical history gathering phase of the appointment. Okay. But poor patient memory recall, stroke information retrieval, on the affects the quality imparted to a doctor and his or her ability to make an effective diagnosis, which feeds into his decision making in regards to treatments, management, and so on. Okay, then you have the patient, and memory from medical history, like other forms of autobiographical memory, is found to be flawed, incomplete, and erroneous. So that causes a big problem when the patient is being asked questions and they can't recall exactly what it is the doctor needs to know in order to arrive at a diagnosis. Okay. In actual fact, patients fail to remember 40 to 80% of health-related data imparted to them by doctors almost instantaneously. Now, that's staggering. So if I'm forgetting that amount of information when I leave the medical appointment, how does that affect me in terms of adherence, in terms of the medications I'm taking, the treatments I take? If I'm a carer, how does that affect my ability to recall what happened at the medical appointment to my spouse, etc.? So it's a fairly significant problem, memory, and our inability to remember, folks. Then we have the process, right? So there's two main processes which require memory within the medical appointment. The elicitation phase, that is when the doctor asks you about your current well-being, your medical history, appointments that you've been at, maybe other care providers, or your medications, and so on and so forth. Then we have the elucidation phase. That's the point where the doctor explains his diagnosis, discusses treatments, and so on and so forth, care plans. And that is going to have a direct implication, as I said, in relation to adherence. And this is the data, okay, which happens over time, which in my case is over, almost 49 years, okay? Illnesses, symptoms, medical therapies, medications, and encounters with other clinicians. So what are the challenges that we're seeing in relation to memory recall? So what I did was I conducted a systematic lit review of all the papers in relation to memory recall, okay, that are out there for the last 43 years, okay? What I found was one of the most significant was forgetting, okay? And if we look at Schachter's 7 deadly sins of forgetting, we see that forgetting is actually in many, many different forms. Transience. As time progresses, we forget events, we forget bits and pieces of our health journey data. Absent-mindedness. This could be when you're inside in a medical appointment and the doctor is explaining things to you. Nevertheless, you could be distracted perhaps by a sick child if you're a carer, or perhaps by the fact that you're feeling fairly lousy yourself. And that affects our ability to encode information within our brains. Blocking, when we're trying to think of a particular medication, for example, or a particular other event, that we get blocked by similarities, we'll say, in events, or similarities in medications, etc. Okay, and so on and so forth. Bias obviously falls into that, and persistence. For example, events that we may want to forget because they cause us pain in remembering them. Nevertheless, they persist in our memories. Health literacy, right? Defined by the World Health Organization as the cognitive and social skills which determine the motivation and ability of individuals to gain access to understand and use information in ways which promote and maintain health. In a medical appointment, for instance, literacy means the ability to identify, to understand, interpret what the doctor may say to us, create, communicate, compute. Okay? Low health literacy is reported to be widespread in the public at large, particularly in those with chronic diseases. In actual fact, in the States, they report that 75 million people have low health literacy. So if we don't understand and it affects our communication, but if we don't understand something, how are we meant to remember it? Okay? So literacy is going to have a direct ability on our ability to remember and our ability to later communicate those memories. So it's essential, folks, that we have a level of health literacy that facilitates communication, understanding, which directly impacts on our memory. Emotional state. This was the third big, I suppose, area in which I found there was an issue in relation to memory recall. Heightened emotional states can affect human cognitive abilities, such as deficient memory recall. Okay, so this is one of the tables, and I'm sorry for the amount of data that it's, but I just draw your attention there to areas that have been overlooked: trauma, pain. Okay, we know that as patients with CF, sometimes we experience pain, be it pleurisy, be it, you know, the damaging of tendons due to certain medications, and our ability to describe this is difficult. Okay, nevertheless, we see in literature that this isn't reported on in pain as a concept. Embarrassment. Okay. And we see white coat syndrome, even though it might manifest, I suppose, in relation to other areas above, such as stress, hysteria, you know, hopeful, tensions. These are areas I would think that in relation to emotional state and memory are probably being overlooked, and therefore serve as possible future opportunities for research within CF. Disease type, okay? In actual fact, in relation to disease type, only one paper referred to respiratory disease as being a possible challenge for memory recall, okay, with patients. Research in this paper said that research in this medical system is important as individuals with chronic obstructive pulmonary disease, COPD, significantly, if not modestly, decreased their cognitive abilities, particularly in abstract reasoning, recall, and the rate of execution or performance when weighed against controls. So therefore, one may ask the question, is having CF, does it affect your ability to remember key facets of data or of health information within your medical appointment, and indeed without it, outside it? So this is a model of the elicitation based on all those findings that I created, which shows basically what memory recall means in terms of the various declarative long-term memories used, the various challenges. But as you can see here, there still remains many, many questions. What are the interactions, for instance, between declarative long-term memory and the recall challenges identified? What are the interactions between the declarative long-term memories used? And indeed, what are the interactions between the various challenges that exist and that have been identified in literature, and perhaps many more that are yet to be identified as reasons why we find it so difficult to recall our health journey, our health data within medical appointments, but also recall what has happened within a medical appointment, and what also, I suppose, is happening outside of the medical appointment. Okay. So thank you very much, folks. And if there is anyone has any interest in, I suppose, more of a greater depth and data around that, the quick presentation I gave, that's the paper that has been recently published. If anyone has any interest in contacting me, that's my email address as well. Okay, thank you.
That's fantastic. Thanks, Michael. That was really interesting and quite startling, some of those statistics as well about the amount that gets lost really between arriving into the appointment room and leaving. I think probably some food for thought for the CF teams as well in that context. So thanks for sharing. That's fabulous.
Yeah, thank you.
Hopefully you'll stay on for the Q&A, which is coming up towards the end. We have one final speaker patiently waiting for us, and that's Dr. Tamara Vag. So hopefully we can connect with her. Dr. Vag has done quite a bit of work in multimedia and CF and looking at how digital health can change the outpatient experience. So welcome, Dr. Tamara.
Thank you, Patricia, and thank you for the opportunity to present today. I really enjoy it. So we have a number of digital health and medical multimedia projects going on down in the Cork Adult CF Centre. So one of which is Who's Talking About CF. So that's analysing internet postings related to CF. We have Virtual Transition, which is our virtual reality tool. We're in the process of developing our website, 3cf.ie, which is going to be our one-stop shop for all information regarding research and care in the unit. The Virtual Doctor, which is an interactive tool for unscheduled visits, and we're also working on our own telemedicine study. For today, though, in 8 minutes, I'm just going to talk to you about Who's Talking About CF and the virtual transition. So first of all, as the internet is becoming more popular, more powerful, and is connecting us more and more, we are actively seeking out more medical and health information online. And there's research out there to show that that can be quite a beneficial thing. But there's also research there to support the opposite. So it can be quite a negative thing. The World Health Organization are saying that not only are we in a time of a pandemic, we're also in a time of an infodemic, because there's so much information out there and so much misinformation. So we were interested to learn what's it like to try get CF related information online, and what's it like to try navigate that space. So to do that, we used a tool called Google Alerts. It's a notification detection tool. Simply what it means is you put in a term of interest to you, like cystic fibrosis, and every time it pops up on a new online posting, an email will be sent to you with details. So over 6 months, we tracked data for cystic fibrosis as well as 26 CF related terms. And we did that in 2015, and we repeated it again in 2019. We're also interested to learn how CF compared to other lung conditions like asthma, COPD, and lung fibrosis. We recorded 1 month data for them as well. And the kind of data we recorded were the link, the type of website, the title, and where the website came from. So some of our findings around this, first of all, CF is talked about a lot online. So in 2015, we had about 3,500 alerts, and this increased in 2019 to just shy of 5,500 alerts. So not only is it talked about a lot, it's increasing in popularity. We're also seeing an increased number of blocked alerts, and that's directly affected by GDPR. For both years, we saw that the US generated the highest number of alerts. So I think it was about 56 and 57% respectively. In 2015, we saw news-based items were the most common alert, and that's probably reflective of the emergence of all these modulator therapies. But in 2019, we're seeing a shift. So now we're looking more at financial opportunities. We had 26 CF-related terms, so I don't have time to go through them all, but I just wanted to highlight some of the biggest changes we're seeing. So there's lots of bugs out there that are increasing in popularity. Pseudomonas, Burkholderia, and Mycobacterium abscessus have all increased, but also other CF-related conditions that are outside of the lung are being talked about more. So liver disease, renal disease, fertility, and pregnancy are all increasing in popularity now as well. And when we compare it to the other lung conditions, unsurprisingly in 2015, asthma was the most common talked about lung condition. And CF and COPD were kind of a similar magnitude, but this all changed in 2019. So now CF was actually more commonly discussed online than asthma. So, of course, the COVID-19 pandemic has probably shook the landscape for us. So we're repeating the study currently. So as of now, we're about 26 days into the study and we have about 259 alerts. So we're getting about 10 alerts per day for cystic fibrosis. So I'd like to talk to you now about our virtual transition tool. So I've actually presented this in the past, so just a little recap on it. The virtual transition tool is our virtual reality tool that was designed to help patients and their family feel less anxious about transition. It wasn't there to replace any part of the current model, not by any means. It's only there to help and assist. Just since presenting it last, we've actually moved on to interview 4 pediatric patients, 5 adult patients, their families, as well as staff in both peds and adults. And what we wanted to learn was about their experience with transition and also what initial feedback on the virtual reality tool. So we spent about 30 minutes talking about transition and then 10 minutes at the end talking about the virtual reality tool. So these interviews generated a lot of data and probably too much to go through today, but I'd just like to highlight some of the major findings to you. So major themes were things that were discussed by all groups. So the current model that's being used in Cork works well. However, there are certain aspects of the model that sometimes don't happen, like meeting the new team and the new unit in the adult unit before transitioning. And this is usually down to resources. We also saw a conflict between preparation and awareness. So the teams work very hard to prepare the pediatric patients to have the skills necessary to look after their CF in adulthood. But when interviewing the patients, they actually felt unprepared because they weren't aware that they were developing those skills. There was lots of discussion about the fear of the unknown from both the families and the patients. And familiarity came up as a really important thing to patients and their families. So building that strong relationship with their MDT, seeing their unit and making these clinic visits in this new place part of their routine, it was really important. So for the minor themes then, so these were things discussed by one or more of the groups. There was the perception from the peds that when they transition, there will be no support for them. And that caused a lot of fear. And for the adults who had already transitioned, they had the same perception, but once they transitioned, they realized that this just wasn't the case. For all the families and the patients that I interviewed, the first day in the unit was actually the first time they got to see the unit and meet the team. And those first impressions were actually crucial because seeing the facilities and getting the first impressions of the team helped alleviate a lot of those negative feelings and also gave them the reassurance around transition. Something else that was noted that was quite interesting was that parents change in their role. So they go from being the primary carer to now more supportive role. And in the current model, there's actually no official way of transitioning a parent. And this is something that'll probably be needed in the future. And from the patients, then they also felt feedback was important. So sharing testimonials, sharing experience of what the transition process would be helpful to them in their fears of the unknown. So when discussing about the virtual reality parts, then what we found is all the pediatric patients actually had smartphone-based VR headsets. 4 of the peds and 4 of the adults actually felt that this tool would be useful to them in their transition and it was something that they would like. The parents felt the same, and one parent went on to say that it could be exciting for them and even make transition feel more of a celebration, which it should be. One adult patient felt the tool wasn't for them, but they could see application with other patients. 3 of the team members that we interviewed in the adults felt the tool could be useful, and the 4 MDT members who were in the pediatrics felt it was unnecessary. But these interviews took place pre-COVID, and now that medicine is becoming so virtual, these opinions could have changed. So for the 4 pediatric guys that we interviewed, we invited them back to test the tool. So we set up the tool inside the unit and they could come in and test it in between seeing the different MDT members, and we gave them this short survey to get some initial feedback. So what we found across the board is it's quite positive. Patients felt it was useful, it helped them get used to their environment, and it's something that they would like as part of their transition. But one patient went on to say it's something that they'd like to use more than once. And this brought up the question for us, how can we make it more accessible to them when they're transitioning? Because as we've learned, the current model works well, but sometimes certain aspects of it don't happen just down to poor resources. So we wanted to make it accessible to patients so the same does not repeat. So what we've done as part of our website is we've made a whole section dedicated to transition. So you can now go, you can meet the team virtually. You can see everything that you'll be expected to do on your first day in the adult unit. You can see testimonials from patients who have transitioned previously, and now you can do interactive virtual reality tours through the website. So you can use it with your smartphone VR headset at home. If you don't have one, you can just use your smartphone, or you can just click and drag and move it around. So if you'd like, you can actually take a virtual tour of our unit right now by scanning the QR code, or you can check back on our website, which should be launched in the next week or 2. So that's everything from me. And I'd just like to say a big thank you to everyone who's been involved, the teams I work with, and a thank you to CF Ireland for all your support. And the references I use are there. And my email is there for anyone who'd like to chat or ask questions. I'm always open.
Thank you so much. And thank you for sticking to time as well. I know it's a difficult ask when you have such a broad scope, but it just gives us a lovely flavour and gives us an opportunity to share with a wider audience. I'm going to ask you to stay there and also invite back on Dr. Audrey Tierney, Dr. Rini, Dr. Martina Hayes. So hopefully everybody will be able to see everybody. And we did get quite a number of questions, so I'm going to have a little look at those and share them with you. I know that there was quite a few questions, which is lovely, so people are really actively getting involved. I know that there's one for Dr. Rini, and she wondered, how did people with CF cope with mental issues during the pandemic? Did they give you an insight into that a little bit?
Yeah, we actually looked at how children manage their, how parents and children with CF manage their mental issues, and there were a few things they did, like they did breathing exercises, meditation, and they read books. They involved their children in art and craft activities, and also, playing indoors and also communicating with their loved ones. And we also looked at it based on age of the child, and we saw that younger children, they were more inclined towards reading books and doing art and craft activities as compared to the older ones. Like above 10 years, they were inclined more towards communicating with their loved ones, and also they were more inclined towards breathing exercises and meditation and all those things.
Different outlets at different ages, it seems.
Yeah.
Brilliant, thank you. We had a comment in relation to Dr. Hayes's piece about oral health, and I'll just read the comment directly. It says, I have 3 sons with CF, and this is the first I've heard of any adverse impact on their teeth, and I'll be talking to the dentist ASAP. Well done. Any comments on that?
Well, I would say there were a lot of studies done in the 70s and 80s looking at the oral health of children with cystic fibrosis and comparing it to that of their siblings who did not have cystic fibrosis. And they actually, even though they had a high calorie diet, sugary syrup medications and other risk factors, they actually had less dental disease than their siblings, which was really surprising, and the research stopped. But it started to show that in the teenage years, there was a bit of a crossover. And the thought was that because kids were on a lot of penicillins, that effectively killed off the bacteria that cause decay. But in the teenage years, when medication changed towards focusing Pseudomonas and towards inhaled medications, that actually that protective effect looked like it was wearing off. But because of the life expectancy at the time, the research couldn't follow it through. And that's why we're focusing really on adults to see if that crossover happens. So for children, I actually think that children with CF seem to have a low risk factor, but it is still important because of their high calorie diets, because of medications, that they would be regular dental attenders and get into those habits so that there aren't problems when they enter adulthood.
Super. And I think we had a similar question that was looking to see, would dentistry be sort of almost included as part of the team, so maybe in a broader sense.
The next few years we're involved with the adult CF unit here, but certainly I think when we did the questionnaire with the general dental practitioners, initially I think like the majority of dental practitioners had treated at some stage in their career somebody with cystic fibrosis. Okay. And initially they said that they were confident treating people with cystic fibrosis. But when we presented them with a series of medical histories and clinical scenarios, like somebody with a toothache, somebody that you needed to do an extraction on, somebody going for a transplant, how would you manage it? Yeah. They very quickly realized that the list of medications can be very intimidating for a general dentist. And that was when we started getting all the emails saying, we actually know very little about this topic, and hopefully by raising awareness, I think it's important that general dentists are the people taking care of people with cystic fibrosis. So, but I think there is an education piece to be done around that.
Absolutely. And I'm sure it's something that we can make sure from CF Ireland's perspective that it's included as part of our information and leaflets and supports.
Yeah, and we're hoping to, we've started working on one leaflet with the dietitian here in the adult CF unit about oral nutritional supplements, because that was our first one. And we have another one in development on bisphosphonate medication as well.
Okay, and while I have you, we have one other question that's specifically come in, your fierce demand today. Is there anything in particular that we should ask? So I think this is from a parent. Is there anything particular we should ask a dentist to check or from a person with CF, if they're in for their own checkup, should they ask the dentist to look at anything in particular?
The most
or?
common things would be to look at, first of all, to inform the dentist fully of your medical history. A lot of dentists, as I say, it can be a little overwhelming, and they think cystic fibrosis and they think lungs, and they're not thinking diabetes. So you should have, in adulthood, a regular gum disease check as part of your checkup. Also, because of the gastric effects, you know, looking for signs of reflux, because once the enamel is lost, it's really hard to replace it. And if there are signs that somebody has like a high dental decay rate, and obviously like that, if people are on nutritional supplements, they're on them for a good reason. And I'm not saying they stop taking them, but we could prescribe a high fluoride toothpaste. We could bring them in for more regular interventions. So it's just keeping the dentist informed of everything so that they know what level of intervention would be appropriate.
Great, they can kind of actively manage it as it goes along. Great.
Absolutely. And the other thing just to point out is it might be worth also asking your dentist for like the first appointment in the afternoon or the first appointment in the morning, so you're not sitting in a busy waiting room. The dental chair water lines will have been cleaned. And it's just important, if it's your first time going somewhere, to say over the phone, oh, will you let the dentist know I have cystic fibrosis? Because if the dental nurse has a cough or a cold, it's just to swap around with a different dental nurse. But you know, when it's your first time attending, it's really good to have that information in advance as a dentist, so that we can keep things as safe as possible.
That's fantastic. Great tips as well. Michael, there was something that came up during your talk that kind of daunted me slightly, and it was 40 to 80% of what was information that's given in an appointment is either lost or is retained. I wasn't sure which.
Almost instantaneously, and I suppose the factors for that, I suppose the medical appointment by its very nature can be stressful, not just for patients, but for carers as well, you know, and there's an awful lot communicated within that very narrow, I suppose, what can be a 15-minute, although if you're going, you know, for an annual assessment, it can be longer, you know, so there's a greater amount of information. And I suppose what becomes even more complex from a patient or carer perspective is that, you know, depending on the frequency of your appointments, but they also are very alike in terms of what's done. One appointment seems to merge into another, and Ruben is actually published on that then to identify what happened at each appointment actually becomes more arduous for the patient or carer, you know. So hence it becomes imperative that you do try to capture what's happening at individual appointments, for the very reason that Dr. Martina Hayes was saying there, so that when you do go to your dentist, you have your medical history and it's accurate, because they're using that data in order for them to arrive at a decision, be it a diagnosis or what treatments, etc. You know, so I suppose it's one of the things that are overlooked. Humans, by their very nature, are use your memories all the time, be it prospective memory, remembering to remember. In this instance, if you're going to a dentist, it's remembering to remember to bring your medical history with you, your medications, etc. You know, so I suppose memory is something that we take for granted very much, you know.
Absolutely. Dr. Tierney, I just had a quick question for you as well. And I suppose it was a phrase that Dr. Vag used, and it was about transitioning the parents. And I think there's probably, I'm just curious about your thoughts about transitioning the parents around diet and the impact of the new CFTR drugs.
Yeah, absolutely. And again, I suppose it's to say to work with your dietitian on the team around the particular, the child or the adult's particular BMI that they're at and their particular needs. And, you know, most patients or most people with cystic fibrosis can meet their energy and their nutrient targets in a healthy way. So there's lots of ways to achieve that. There's healthy fats, you know, the avocados, use of olive oil. There's ways that we can try and meet our energy and our nutrient targets in healthy ways, but it's trying to be savvy about it. It's trying to make sure all the marks. It can be kind of a bit, but if you sit down with your CF dietitian, they can work through a particular meal plan, you know, personalize it to you. But I think, yeah, the narrative needs to change around, you know, high fat, high sugar, and that doesn't constitute a nutrient dense diet. It can be high energy, it can be high in the healthy fats, it can be high in the good types of protein, high in carbohydrate, but it can be healthy overall, so that your child can grow in a healthy way, meet their BMI targets, but not, you know, jump past particular percentiles or BMI targets also. So I think working with the team, working with the dietitian is really important at this stage where we're at with the therapies. So yeah.
That's brilliant. And I have, I think I have maybe 2 minutes left. So I have a question for Dr. Bagg. And this is an observation, I think, came in from a parent or a person with CF. When you see Google alerts increasing significantly, do you check it against events such as the conference like this or CF Foundation in America events to see if that might be the reason for a surge?
Yes, yeah. So that's something we're working on at the moment. And actually, interesting, you should say that we had a bit of a surge this week from Ireland because of 65 Roses. So there's a few news articles coming up about that. So yeah, there's definitely events that would, or let's say particular research papers that come out. And then there'd be a lot of, say, particularly in the US, charities that would translate the heavy research into digestible information. And and because of that could cause a surge. But to be honest, since 2019, it seems to be the financial opportunities. So I don't know necessarily if there's a correlation to the research that's happening. It seems to be a little delayed. So it's talking about modulators. In that case, it could be maybe a year or so behind.
That's interesting. So sometimes there can be a lot of noise, but it's useful to drill down a little bit and see what's really going on. Unfortunately, we have to wrap up at this point. And I just wanted to say thank you so much for your time. We're looking forward to hearing and keeping track with how your research moves on from this. And hopefully we'll get to see you again at a future conference. So thank you, everybody.